Dr. Spinnell, welcome, and it's really nice to see you. I would want to start by asking you about your practice. If you can tell us a little bit about your practice.
Great. Well, I appreciate the invitation, Praveen. This was really a welcomed way to start my Memorial Day celebration. So I'm a gastroenterologist practicing in Englewood, New Jersey. Englewood is in Bergen County in northern New Jersey, right across the bridge from New York City. And we were, sort of in the hotbed of the COVID pandemic. We're a 11 physician GI specialty group with some roots in internal medicine. We have one nurse practitioner. We work out of an ASC that is partly hospital owned. Middle of March, things had really exploded, at an exponential level. Mm-hmm. And Bergen County has remained a red zone hotbed.
And you worked in a COVID unit at the hospital, at Englewood Hospital. How was that experience?
Yeah, it was incredible. The hospital was sponsoring weekly or biweekly meetings, sort of updating what was happening at the institution. And as the number of cases was mounting, there really was an effort to convert the hospital, increase its ICU capacity, and turn the majority of the units into COVID units. There still was an incredible shortage of manpower. So there was an outreach to some of the specialty physicians to assist. I devoted a little over 2 weeks to the COVID units specifically. I wanted to carve out a block of time, over that period, I was involved in the care of, over 40 COVID patients.
How long has your practice or your surgery center been closed?
Our last day of full operation was on March 16th, and it was the weekend before that Monday that we really began to see the number of cases in New Jersey skyrocket. And I believe on the 13th, the governor declared a state of emergency. I was doing endoscopy that Monday, the 16th, and there was great concern because the unit didn't have appropriate PPE. Many of our cases either dropped off because of patient concerns, and we had to cancel quite a few because we were concerned about upper endoscopy and not having proper protective gear for the staff, the physicians, the anesthesiologists. The unit officially closed on the 16th of March. I'm happy to report, though, that we are scheduled to open up this coming week on Thursday, May 28th.
And how are you transitioning, from this phase to the phase of opening up back again? Do you have enough PPEs? What kind of staff training and physician training did you have to undergo in preparation of this opening?
Yeah, so that question really encapsulates my last 2 weeks because it has really been a challenge. We have 3 rooms in our facility, and what we've opted, at least to start, is that we're going to have one provider toggling between 2 rooms. Mm-hmm. We are going to schedule cases every 45 minutes to an hour. And for the first weeks, we plan on scheduling no more than 12 cases on a given day. Part of that is because of our lack of PPE. Part of that is to gain comfort for the staff and the physicians. Many of the physicians have not been in the hospital environment during the pandemic, and they're not familiar with protocol. And we've done extensive training. We've been able to secure some PPE. The biggest variable are the N95 masks. As a result, we have actually purchased some respirators, a number of them for the entire staff. And those are hopefully going to arrive this week. We do have enough N95s to last maybe 10 days, 10 working days. So those are the limiting factors. We're going to really start at a snail's pace. We spent 3 days training the staff last week, and we've really put in a protocol that I think is going to be quite effective. The detail on that is because we're in a red zone, as per our hospital protocol, which we will be following, and now it's mandated throughout the state of New Jersey, all patients receiving elective procedures, and we wouldn't consider our initial patients to be elective, they're more semi-urgent cases. All patients will require a COVID nasal pharyngeal swab done 72 to 48 hours prior to their procedure. We'll have documented a negative swab. Upon the patients are then asked to self-isolate from the time of their swab till the time of their procedure. They'll arrive at our unit where they'll be questioned by a nurse. They'll get a temperature check. And we will also be evaluating them with pulse oximetry. And then assuming that their COVID is negative and they haven't answered affirmative to any of the questions, they'll be admitted and the procedure will take place. We've also asked our staff if they were interested in getting swabbed and antibody tested prior to restarting. And all of the staff were interested, and I'm happy to report that everyone was negative. But this is the protocol that we set up, and I think it's the best way we can maintain safety for our staff and our patients.
Yeah, I'm glad to hear that everybody tested negative. Now, when you were going through this training and everything with staff, what kind of concerns did they have? What were they fearful about?
I think, I think it's fear of the unknown. There is not a single employee in our unit that has not been affected by this pandemic. Everyone knows someone who had the virus, knows someone who was hospitalized, and we've had several family members that have lost relatives. So there still is great concern about exposure. And I think that we've really tried to reassure the staff that with proper PPE, they can remain safe. When I was working on the unit, I was very concerned about my exposure. I have a young family. I was away from my family during my time of work, and I was concerned about when I did reunite with them that I would be bringing the virus back. And I think this is a big concern that the family has, after the workday when they return home, what will they be bringing with them? I was able to reassure them that, after, my stint in the COVID unit where I was seeing, 10 or 12 COVID patients a day, at the end of my term, I nasal tested negative and my antibody was negative. So the PPE clearly works. If it's used properly and you're absolutely fastidious about the details of donning and doffing, I think you can remain safe.
So after you start and someone tests positive, so you end up discovering that a patient was infected, maybe after you do the procedure or after you've seen the patient. Do you remain open? Do you close? What is part of your protocol? How have you thought about that?
Yeah, I mean, that's a great question. The big concern is that, we don't want our unit to be associated with any infection. because clearly as things open up, everyone is going to be hyper vigilant about new clusters of cases that emerge. Our plan is that obviously we are not going to admit anyone into our unit that either tests positive or answers affirmative to any of the probing questions, and their cases can be deferred. But after their procedure, typically we would do a follow-up call on, their first post-procedure day. Our plan is to extend that. So we will follow up the day after the procedure, a week after the procedure, and 14 days later. And this is our way of contact tracing, making sure that nothing has happened to the patient after an exposure. And this will all be tied in, with the local health department. If we do find a positive, obviously we're going to need to re-explore. We've also offered to our staff, they will be tested daily on arrival at the unit with temperature checks. We're going to be logging all of that data. And if they do want to get periodic swabs or periodic antibody testing, that is available. And our hospital network has really ramped up its capacity to provide necessary testing, particularly for healthcare workers.
Mm-hmm. I want to ask you about what must be confusing, for you right now, both as a clinician and as a physician partner or business owner.
The financial piece is clearly a struggle. We furloughed our entire ASC staff. And more than 50% of our office staff, during the height of the pandemic. We're bringing back 50% of our staff in the ASC, and about 75% in the office as we ramp up and start to see patients. We were lucky that we were, very aggressive about applying for the PPP loans that were available, and we did receive all aspects of the loan. And that has carried us through. We are now obligated to try to utilize that money during a certain time period. So having our staff back and paying our staff is very, satisfying. Most people want to come back. Clearly there are some people that were affected by the pandemic in a variety of ways. Some are still at home mourning. Others have childcare responsibility, given the fact that schools are still out. Summer programs will probably not be available. So these will all be challenges moving forward. The financial piece of it will remain a challenge. I don't think, we can expect things to get back to normal for quite some time. I think it's going to be a matter of just sort of surviving and working our way through this. The financial piece will hopefully come maybe toward the end of the year, but that's all contingent on, whether or not we see a second wave. But at this point, it's just a matter of staying positive and trying to forge forward. I don't have a better response than that. It's scary.
Do you foresee patient behavior change during this period? Do you think that patients would think that if I can avoid screening colonoscopy, maybe I should? Why get into a healthcare facility? If at all can be avoided?
I think that many patients are going to feel that way. And I think that the internists that we work with are quite sophisticated and they're aware of all of the screening tools. We have seen a significant uptick in Exact Science and Cologuard use over the last year and a half. I mean, it's there. We utilize it ourselves for patients that are, higher risk for endoscopic procedures that do require a screening test. So I think, to bury your head in the sand and think it's not going to have a major impact, I think is false. It's here to stay and it will continue to grow. I think we have to be creative in terms of, how we structure our practice moving forward. There are, many services that we provide. We continue to expand the services and patient offerings. And I think we need to be innovators. But I think Cologuard is a force, and I would rather be a part of that force than to fight against it.
Mm-hmm. Talking about consolidation in your region, and so you've had small practices talk to you, smaller practices call you, share their concerns. What is the vibe in your area about consolidation?
So, consolidation has been in and out of New Jersey for the last 4 years now. There's been multiple attempts at trying to form a large supergroup, and private equity has had its hand in New Jersey for quite some time. I know that there were quite a few deals that were being explored. Our group has certainly considered the possibility of syndication, either with a private equity group or with a large hospital network. We have been in talks, and we are trying to decide which direction we want to go. I'm amazed that some of the groups that have been exploring investing in gastroenterology groups in New Jersey have fallen off and have not been expressing the same kind of interest as they were months ago. But there still are some very dominant, large private equity groups that are still showing interest. So the talks are ongoing. There has not been a major transaction in New Jersey, but I anticipate that in the months to come, something may finally come to market.
If the valuations change, would the interest from doctors also change?
I think so. I think that a lot is going to depend on whether or not it makes financial sense. But more importantly, depending on what your horizon is, I think we know that consolidation is really the only way forward. In order to mount some strength against the payers, groups of 2 or 3 physicians won't be able to survive. Larger groups have a better chance, but I think the weight of a private equity partner or a hospital partner is really what's needed in order to see some light. Clearly, as a result of the pandemic, our expenses are going to increase significantly. And the only way we can weather those added costs is if we're part of a larger entity and have the ability to negotiate. So I think consolidation remains the way of the future.
Mm-hmm. What kind of advice do you have for GI practices or endoscopy units that are outside of the red zone and looking to you? You're in the thick of things. And you're opening up now.
I don't think you can underestimate, the variety of ways that this virus presents. We have all been blown away by the variety of clinical manifestations and presentations. I remember a patient of mine who was in the emergency room with what sounded like peptic ulcer symptoms. They did a chest x-ray on him. They saw bilateral ground glass infiltrates. He had absolutely no respiratory symptoms at all and was diagnosed with COVID. So my point is that I think we have to take this virus incredibly seriously. I think that the PPE is critical. We have to be sensitive to our staff and make sure that they feel protected. And I think appropriate questioning and screening of our patients remains essential. I mean, even in people that are outside of red zones, I think we need to sort of change our approach to um, donning and doffing PPE. And I think we need to remain absolutely fastidious about the details, of putting on the equipment, taking off the equipment, using shields, things that we very often took for granted in the past really need to be adopted, and we need to be absolutely strict, and we need to call each other out when people are not doing things properly, whether it's a physician colleague or a nurse or a technician. We really need to be on top of each other, because that's the only way we're going to be protected.
Mhm. Dr. Spinnell, thank you very much for sharing all these insights. Incredibly useful. And I wish you all the best in opening up this week. And I wish you well. I wish your staff well. Take care. Thank you.
Okay, Praveen. Thank you very much. I really enjoyed it. We'll talk soon.